name's Janette Hughes. I'm Director of Planning and Performance for the Digital Health and Care Innovation Centre in Scotland, a big title. So we're commonly known as DHI, and some of you would have seen George Crooks. George is my Chief Exec, and I've been working in this sector for the last 17 years, and I'm going to talk about some of the frustrations I have. Not to look back, but to more look forward and how we can actually scale digital health innovation. I suppose this is our 10-year strategy. We are the National Innovation Centre for Scotland. So we help all universities, NHS, municipalities, third sector, but importantly, we help our citizens design what services they want to see in the future. And I think often that is a missing part of the jigsaw. We have a range of living labs to do that. I think in the past, what we haven't seen, and I think that's been echoed by the presenters that we've already heard, is that we haven't seen too much scale. And that is certainly a personal frustration of mine. And I'll talk a wee bit about how we actually move quicker to scale using data and that integrated health and care agenda to leverage that. DHI as a National Innovation Centre is less interested in making bigger hospitals. We are much more focused now and asked by government to focus on prevention, detection of diseases in the community, trying to make sure that people can get out of hospital or even not go into hospital with innovations and, I suppose, projects like Hospital at Home, and allow people to stay in their community for as long as possible. I think one thing that Mark had asked me to, and Tino had asked me to speak about, was the prevention agenda. And I've worked in that kind of area for a long time, and there is key barriers. I think Hans and others highlighted them earlier, but one of the biggest barriers for prevention isn't the will, but it's actually the investment and reimbursement models. So I'm not going to go into that in too much detail, but I'll talk about that a wee bit in the future. And this is a big deal, and it always has been a big deal. I was presenting at the Global Health exhibition in Saudi Arabia last month, and Frost and Sullivan actually presented a slide which even I was surprised about. What they said is today people are getting long-term conditions at the age of 50, 55. And by 2040, Frost and Sullivan are predicting that people will be getting long-term condition, onset of long-term conditions by 3035. So we have a massive time bomb just now with the demographic shift, but in the future, how are we going to deal with that kind of prevention agenda? I suppose the easiest way to do it is make sure that you have the leadership at the government level. We have a number of different strategies in Scotland. I think Donna touched on some yesterday, but it's actually getting that leadership to make sure that they realise prevention is a key part of the solution, and digital obviously following suit with that person centre in the middle. DHI, and this will become obvious as I talk through some of the case studies that I'm bringing to life. The technical innovation part isn't difficult. We've heard of loads of solutions in the room today of people that have got technical solutions. And as Raquel said, I think it was yesterday, service innovation has got to be considered as early as possible. And business model, and I think Hans or somebody spoke about that as well, it all has to merge. And we talk about interoperability as if it's just technical interoperability. These things have to interoperate. Businesses have to develop products that can be sold to the service. The service needs to want and understand how digital is embedded. And then obviously the technology's got to work, it's got to be safe, it's got to be secure, it's got to be usable. They're all givens, I suppose, in this world. So we have a readiness level, and the reason I bring this up is we have got to make and take people on a journey with us. So all we do is co-design with clinicians, citizens to understand what they want. And I suppose to point to Raquel's kind of question to the panel of speakers is we need to understand what the demand is. and we need to get everybody's agreement of what the priorities are. We need to understand what the current state looks like. We need to take people on that journey to actually make them invest and take ownership of the future state. And that has to be de-risked from a research and development perspective. We can't invest in real world evidence if we don't do these things first, because the buy-in won't be there. And that's why we've been littered, I think, with pilot projects all over the world. And then once you do realise that, then how do you build the evidence? And how do you take it to a point that you can convince the decision makers around the table? And that is evidence-based. And it's evidence-based that it's cost-effective, it's going to save time, saving money is one of the key points, certainly, that we find in the UK. If it's not going to save money, it's a very difficult business case to get through and to be, I suppose, endorsed by any board. So these are the stages in a kind of systematic way that we go through. And what people are looking for is technology that can scale. And I talk about scale, I talk about national scale for Scotland. Companies that can commercialise for economic benefit, and services that actually use the products that are embedded now within the service. Don't just, it's not a vanity project, you get it and then it's never used, because it's got to bring benefit to all these stakeholders. And I don't think we should be shy about that. Another thing I'm going to say about the future of health and care and integrated health and care is, and it's great that we've all been speaking about electronic health records and the health and clinical data. We believe the future from an innovation centre is around the social determinants of health. And that's, I think everybody probably nods and agrees with that. I suppose the innovation is, how do you actually do that? How do you move from a clinical system that sees 20% of you when you walk into that GP surgery or hospital to something that's much more holistic? And we've done lots of research on that. And we certainly know that our citizens are asking for things that relate to the whole of them rather than just their clinical needs. One of the biggest frustrations that we've found when we speak to citizens and we ask them about health and care and digitalisation of it, is actually telling their story hundreds of times, same story, but to hundreds of different people within the service, and not having them at the centre. So that's something that we've looked at in detail. So looking forward and what we think is the future, we have research and development infrastructure, and we have a personal data store. And what we're testing is, can the person be the aggregator of the data? Can they take their story to the social care department, the GP? And that story would contain more than just clinical. It would contain, are they employed? Are they socially active? Are they mobile? Are they getting out? Are they fit? Do they live in a damp house? Do they live in maybe a deprived area? So again, going back to that social determinants of data, but giving the person the ownership of that data. So we have developed this in Scotland. It's running in 3 regions as a pilot. And I'll just talk about some of the kind of key prevention areas that the government have asked us to look at. Diabetes is massive. I know it's massive in Scotland, but I know it's massive also as a main driver around the world. And our policy is shifting towards, how do we prevent type 2 diabetes? Now, that's not a new thing, but we've done a lot of research, and I won't read all of these out because Tino showed me a 5-minute. I need to speed up, I think. So let me just talk about some of the projects and pilots that we are running, but importantly, I will show you products that are getting to scale. So we've done a lot of landscape reviews to look at what's actually happening. We've got a really good research report that backs up some of the statistics. We know that type 2 diabetes is on the rise. And one group that probably isn't looked at in detail is children and young people with type 2 diabetes, or pre-diabetes. What tools do they have to actually start to change their behaviour? So this is a tool called DigiBeat. We've been helping Scottish Government and our partners look at it, collect the evidence, and the evidence is showing really positive results. And this product will be scaled. Just now, I think there's about 1,700 children that have used this product, and we have about 4,000 as an ambition for the next 12 months. So that is a product that is actually scaling. You can see on the map the regions that we're looking at. Just again, to give you an idea about how we move and how we actually say, where do we go from to, how do we know what's what and where we want to go to, we use our readiness levels to show that. If I talk to the prevention of diabetes and the tools that GPs can put in their hands when they're actually presented with people that might be facing a diabetic diagnosis, we have a tool called the Right Decision Service. It's been rolled out in Scotland, but this specific product is looking at people before they have diabetes and allowing that to be prescribed by the GP so that they can have an educational interaction to understand what they need to do and where they are within that kind of diagnosis process. The other piece is around obesity. So this is, how do you make sure that you're identifying people early on? And we've done a lot of work around the Rural Centre of Excellence, around diabetes, a lot of current state mapping, so that we understand where we are, going back to your point, Raquel, and what the future might look like as a technical infrastructure and how we actually manage and change the business and service model. So I suppose with this one, it's how do we actually move people into a leisure centre pathway rather than getting them just to speak to dietitians at the NHS. That's the kind of conclusion to this study. And the benefits, what is the benefits? Societal benefits, more productivity, environmental benefits, economic benefits, but person-centred benefits. Because if you end up with having obesity for a long time, there's a whole range of diseases that come hand in hand with that, which I know that I'm speaking to an audience that understands that. The last tool that I want to, with my last minute, is to talk about things like loneliness and actually the social challenges that some people face. We've developed a tool, and that's in partnership with a third sector organisation, to look at what the needs of unpaid carers are. Within the UK, we have so many unpaid carers that if they all put down their tools, the whole place would crumble, because they really support our health and care. We're looking at what their needs are and actually trying to connect them better so that they do get better connections within the community, and they can actually take people to those services, whether it's somebody you're looking after with dementia. The great thing is the community connections tool that's been developed and tested around the personal data store actually allows that consent to happen. So if my dad has dementia and he's filling in forms, and then suddenly he's not able to tell that story, I can take over that and push some buttons with consent so that I can actually deal with his data, and that could be sent right into a service. So that the administration of that is very much reduced. Lots of great feedback. I won't go into it just now, but please do come back to me if you want more information about the Community Connections application. And I suppose just to end with, we believe the future's social health determinants data, personalisation, prediction, prevention, but importantly, also R&D that then harnesses things like AI and makes it a better service for everybody. So thank you.